Hi, everyone. To everyone on the line, we'll get started with our webinar in just a minute. All right, good morning, and thank you for joining our webinar today. My name is Donna Klein. I'm a medical science liaison at Baxter Healthcare. And before I introduce our two speakers, I wanted to let everyone know that if you have questions as the presentation moves along, please use the Q&A function, and then we'll answer all of the questions at the end of the presentation. Our speakers today are two key members of a smart pump EHR interoperability project team that took place at Presbyterian Health Services, which is a 9-facility organization located in Albuquerque, New Mexico. And they went live at all 9 facilities in March of this year. So Shannon Burchett is the Pharmacy Quality and Medication Safety Coordinator at Presbyterian Health Services. And her role on the project was the pump drug library programming and updates she was responsible for. She's been a pharmacist at Presbyterian Healthcare for 7 years, where she's taken part in multiple roles from staffing to supervising to her current role as the Quality and Medication Safety Coordinator. Renae Mohammed is an EPIC certified senior analyst at Presbyterian. Her role on the project was she was responsible for the clinical application build. She's been a registered nurse for almost 30 years. She started in adult med-surg, and she worked in home care, chronic wound, vent specialty, and eventually transitioning to neonatal intensive care unit. And after being a NICU nurse for 7 years, she began working in health IT and has been a certified EHR analyst for the past 14 years. So welcome, Shannon and Renae.
Thank you, Donna. So before we get started, I want to do some brief disclosures. The first is that Shannon and myself are being compensated by Baxter Healthcare for this educational event. The opinions that we share about the integration of the electronic health record with large volume infusion pumps are our own and do not reflect the position of our employers, our electronic health record or infusion pump vendors accepting Baxter, nor their affiliates or associates. We wanted to share some definitions of some acronyms that you may hear throughout this presentation. I will not read all of them. I will draw your attention to the first 3 because you may hear those more frequently or see them listed out on slides. When we say BCMA, we're meaning barcode medication administration. EHR or EMR is our electronic health record. And when we say interoperability relative to infusion pump integration, we are specifically talking about the bidirectional communication of data between the electronic record and the infusion, and from the infusion pumps back to the EHR. So our objectives for today, we want to make sure we explain some of the benefits of integrating the electronic health record with infusion pumps. We're going to describe the phases of our integration from preparation to implementation. We're going to discuss some lessons learned throughout the process and share a few of our next steps that we are embarking upon after our go live. Objective 1, beneficiation. One of our main focuses and goals was to improve safety, patient safety, as well as medication administration safety, which also contributes to patient safety. We wanted to improve the efficacy and efficiency of and compliance with the administration of infusion, flush, and carrier fluid orders. We also wanted to standardize and improve the documentation of MAR events and volumes and standardize infusion workflows across the organization. We wanted to improve technology integration by promoting facility formularies and drug libraries. We want and continue to work to reduce or eliminate manual entry pump programming errors. We have certain alerts in place to notify nurses when selected orders do not match the pump entry and or the patient encounter admission or visit. We have the alerts that notify the nurse when entered order details do not match provider orders or pharmacy safety guidelines. We also have alerts to help the nurse understand that primary and secondary infusions, if selected, if they're not compatible, they get an alert. Even with these additional alerts, we still have the goal and are working towards reducing alert fatigue by programming our pumps automatically using the integration workflow. They go to, our infusion rates automatically go to a keep vein open or TKO rate for adults, pediatrics, and neonatals at the end of continuous infusions. And we set it up to go back to the primary infusion rate after intermittent infusions, or what some may refer to as the IV piggybacks, are completed. And with our integration workflow and the way the information flows back over to our EHR, busy clinicians do not have to try to manually recall the details of titrations on infusion pumps. They're able to see a full and comprehensive list of all of the actions that occurred on the pump by simply logging into the EHR and reviewing the information and then accepting the information.
All right, we're going to move on to objective number 2, phases of integration from preparation to implementation. So just some basic criteria for integration. The EHR should be live for at least 3 months so that people are familiar with the use of it and how to navigate. Infusion pumps should also be live for at least 3 months. And then barcode scanning devices as well should be live for 3 months. The barcode scanning devices we utilized during this were rovers instead of using Epic Hyperspace and those barcode scanners that come with those. Something else to think about are the types of pumps that can be integrated. Obviously, ours is focused on large volume infusion pumps. We do have some plans maybe to go live with syringe pumps or integration, but we also use cassette pumps at our sites as well. So some things that EHR and infusion pump integration takes: time, attention to details, capital investment. So when you're looking at analyst hours or staffing for education or upkeep and EHR and pump vendors, all of that investment with those people, a commitment to re-education and ongoing education and support. And just remember that infusion pump integration is not a quick fix and it won't resolve poor pump practices. So real quick, I'm going to review the timeline that we went through for our project. We started meeting with different pump vendors in 2020 to determine where we wanted to move and what direction we wanted to go with. We did update the pumps to allow for interoperability in January of 2022 in preparation for this interop project. And then our official kickoff for the interop and integration project was in May of 2022. So from June through the time we went live at the end of March with all of our sites, we were building, testing different drug builds, making sure the integration worked, making sure all the new barcode scanners were implemented in the timely fashion, and then prepping any training materials that we would need throughout. And below that, you can kind of see the dates that we rolled out. We had multiple facilities and different sites throughout the enterprise that we were integrating with. And so those are the dates that we went live at different sites along the way, as well as, and that included inpatient and outpatient infusion clinics. And then started wrapping up and moving on towards next steps after that. So review of guidelines and assessment. This is something we started off with using ISMP and ASHP documentation that they have out there with regard to integration and implementation of smart infusion pumps. Something to consider: interdisciplinary stakeholder involvement with guarding the pump use and common issues that might occur. Identify those error reduction strategies among multiple areas. So some of those areas are bulleted here. So infrastructure and hardware. So that includes your networking, your Wi-Fi connection, as well as the functionality that your pumps can have for interop. So like I said before, we updated our pumps in January 2022 in preparation for this integration. Looking at drug library and pharmacy formulary to make sure it's standardized and kind of works in the processes that you're trying to integrate. And then any CQI data, this would be compliance prior to interoperability, dose error reduction software, so your DERs, reviewing your hard and soft limits, as well as any alerts that might be occurring. Another thing to look at is clinical workflow. So this ranges from your physician order entry to your barcode med administration, infusion pump programming, proficiency, primary versus secondary, different carrier fluids, and how nurses generally have their workflow out on the unit. Another thing to look at are safety practices to promote readiness. So we were already monitoring our BCMA data and compliance and metrics. So we were trying to get those up to goal and make sure that if there are any areas that need improvement, we did that prior to our integration as well. Some other considerations as far as preparation. Solidify your foundational workflow steps for providers and clinicians. So improve any CPOE by streamlining your orders, your order panels or order sets, and even preference lists that they would have available to select medications. Update and redistribute resource materials that might be useful for integration. So this includes standards for infusion administration and documentation, tips and reminders for how to use the barcode scanners, as well as the infusion pumps. And then make sure that your in-scope departments have enough pumps and scanners that they can utilize this successfully. And then obviously assess and update your Wi-Fi connectivity across the organization to make sure that it can take on that load of having those connect between your EHR and your pump. And then also consider using huddles or on-site training refreshers or computer-based training to make sure that nurses know how to do the basic workflow. This is just a visualization of kind of what the integration workflow would look like and steps along the way. So you have your provider ordering the infusion. A pharmacist verifies the order. From there, the nurse can prepare the pump, scan the patient med, and pump barcodes to implement that integration and auto programming. Then that information will transmit back to the EHR from the pump, as it did from the EHR to the pump. So our team consisted organizationally. There are multiple organizational leaders involved, including operation and nursing leaders, pharmacy and medication safety leaders, different educators that were both unit and clinic based, as well as SMEs and project managers.
And from the information technology side, we had a very large and diverse application team. So from a clinical application team perspective, there were pharmacy analysts, clinical documentation team analysts. We had analysts that represented our emergency department, operating rooms, and training team members. And my function primarily on the team was to make sure that we all communicated. Initially, when you start your project, there is a lot of detailed information, both on your EHR side and on your infusion pump side, that someone will need to have a good understanding of. And then you start just making sure that from all of the different clinical unit perspectives, everyone has an understanding of how integration will work and appear in their area. So there are a lot of similarities, but sometimes different end users' home workspaces look a little bit different. And it's important from a training perspective and from a build perspective that we can anticipate all of those different views that an end user may see in order to help them make it through the workflow electronically. We also had assistance from our interface and infrastructure builders. These are the people who made sure that all of our environments were stood up or set up in such a way that they could accommodate infusion pump integration build, testing and training, and then eventually implementation. So that included our application environment analyst, our interface team analyst, our infrastructure team analyst, and our network team. Because as you heard Shannon mention, and as you'll hear a little bit further in the presentation, making sure that you have good connectivity and that you don't have dead spots where pumps don't connect well in different rooms, or at least being prepared for that, will help you troubleshoot. We also had our biomed technicians who also helped us with the project and preparing for the rollout. So a little bit about our facility and our department scope. Our organization has a total of 9 hospitals, and those hospitals do include 4 urgent care, emergency departments and urgent care departments, 7 infusion. We call them clinics, but in truth, they're areas that can see both inpatients and outpatients. So HODs is what we call those departments. And we had 4 strictly outpatient or clinic areas for oncology and med oncology that were reviewed to determine if they were going to be in scope for the infusion pump integration. In total, we went live with 99 departments. We had 96 departments that were determined to be out of scope departments. And I'm giving you a brief explanation you can see on screen of what we mean by out of scope. Those were those virtual departments or departments where a provider or clinician may log in, but that no patient is actually bedded there. This allows us to route charges, present documentation and different tools for end users, but there is no actual pump integration occurring on those units. And then we decided to come up with a third subset of departments called hybrid departments. For us, these were departments that do administer infusions via the large volume infusion pumps, but they also infuse a lot of infusions via gravity or pressure bags, or they may use syringe pumps most of the time. So we wanted them to have the ability to use the large volume infusion pumps when they needed to, but not have it as a hard stop or a requirement that prevented them from completing other workflows when they needed to. Again, some examples of what our in-scope departments were and what we required. For our in-scope departments, we require them to scan the patient armband, medication barcode, and the on-screen pump barcode. This was the majority of our inpatient units as well as our infusion clinics. Departments that we determined to be hybrid are still required to scan the patient armband and the medication barcode. They have an option to scan the on-screen pump barcode or to skip the on-screen pump barcode scanning, which is not applicable for a workflow. In the event that they do skip barcode scanning on the pump, they are required to enter an override reason for why they're not scanning. And as an organization and an application team, we worked with our clinical informatics experts to determine what some of those additional override reasons could be for those infusions. Again, some examples of hybrid departments for us were our emergency departments and urgent cares, our neonatal ICUs and our nurseries, who sometimes use syringe pumps or may primarily use syringe pumps, and then a lot of our ancillary areas like interventional radiology or MRI. Our out-of-scope departments do not routinely administer patients or admit or bed patients, and we just determined those departments to be out of scope for infusion pump integration. Some examples of those were our occupational and physical therapists, as well as our speech therapists. To give you an example of our medication scope, a total of 3,934 medications were reviewed and tested. Of that group, 2,894 medication records were determined to be in scope, and 1,040 medications were determined to be out of scope. There were a total of 1,392 pump entries that would help clinicians program the pump properly. An example of some of our out-of-scope medications were blood, because they're not dispensed by pharmacy, and medications that are primarily ordered or delivered via syringe pump or cassette pump. An example is cyclic TPN, that we left that out of scope. Other than that, everything else was determined to be in scope. Some of the hardware we assessed, reviewed, and made sure that we tested included our armband label printers, our barcode scanners, and then our infusion pumps. We went live with a total of 2,230 infusion pumps. And all of those have to be built into your EHR so that integration works effectively. So our software EHR vendor, pump vendor, both of those we had a lot of success working with and receiving information to understand exactly what we needed to do to make those two things speak to each other. As far as our server environments that we considered, we had a build environment. We also had multiple testing and training environments in addition to our production environment. So we had a lot of opportunities in several environments where we could go in and make sure that all of the different workflows that we tested worked appropriately prior to rolling it out to our end users. As far as our application environments, it matches our server environment. So again, we had build, training, and production environments. And some things that you may want to keep in mind when considering your environments is what your environment refresh or down schedules look like, so that you can be mindful not to overwrite data that is not yet ready for production, but that you need in order to be able to test and in order to train. You may want to review what your standard migration or your data migration and manual build policies are. There may be times when you need to make adjustments in order to do that quicker, or have things go from one environment to a different environment to accommodate your project. And then I would encourage everybody to use good build trackers. It's very good to go back and make notes of not only what your build is, but why your clinical group made some of the decisions that they made in case they need to be reviewed later. For training and support scope, for our go live, we had training analysts available to build and to prep patients in our training environments, so that our end users had very realistic scenarios. We had in-person lab set up so they could go and work through scenarios in addition to just reviewing that type of information using CBTs and online or paper resources. We had train the trainer sessions. So our clinical application team worked very closely with our actual trainers. That included our clinical practice leaders, nursing informatics, and unit-based educators, as well as we provided support and education materials to our help desk. We had rolling end user training because we didn't go live with all of the facilities at the exact same time. So there was rolling and mobile support that included all of the above, including the equipment at each facility, and then clinicians at each facility could sign up to make sure that they got an opportunity to attend and get that in-person training and get that one-to-one communication with the support leaders that you see above. So again, we use computer-based training, in-person learning labs, as well as electronic resources guides that could also be printed out. And then we also made a plan so that we could address training for new hires or anyone who missed training because the available dates initially were not available. Post-implementation and stabilization for us looked like making sure that we had training materials and resources in the form of people, as well as the electronic documents available to train new hires. We also encourage refresher training so that some of the workflows that may have kind of deviated from what we hoped they were and what we standardized, we can encourage and pull staff back to those standardized workflows. We increased at the elbow support for the EHR and the pump vendors and the project team and everyone else initially, but we eventually went to a model where our help desk is the primary fielder of the incidents and tickets that come in, and then they disperse those out to either biomed if it's an actual physical pump that needs to be updated, or to the different application analyst teams, which may include, again, pharmacy, clinical documentation, our emergency department team or something like that. So right now we're in the mode where it's a lot more unit clinic-based, and we address them based on the workflows that they're talking about and some of the medications that they're dealing with. For the most part, our standard change control processes did not change. For the course of our actual implementations, we did update our process so that we had a quicker way to move in changes as issues needed to be addressed immediately and then resolved quicker. And now we're back to our standard change control processes.
All right, so some drug library considerations to think about and implement before you go live with the interoperability. So the library we had previously had concentrations per 1 ml. You can kind of see the example of the norepi on the left-hand side. And we had mixed units, so micrograms per mil and milligrams per mil, separate medication entries for pediatrics and adults. And then we also had some combination medications that would have dose limits. So those would be like your Zosyn with the 3.375 gram as a combination with the tazobactam. After and implementation phases to get to interop, we had to change the concentration to a total amount of medication over and total volume. So as you can see on the right, the updated norepi has 16 milligrams per 250, for example. We also had to make sure that the same concentration units in the pump match that of the EHR. So here for the norepi example, we decided to standardize to milligrams per mil and remove the micrograms per mil. Also combining pediatrics and adult infusions, if they share the same drug build in your EHR, so that they can have the appropriate connectivity between the pump and the EHR. Or you could also unlink to allow for different specifics. For example, if you have a pediatric patient that's on norepi, you can unlink the norepi and have those specific pediatric limits built in. For example, a 10 ml per hour KVO for adults and a 2 ml per hour KVO for peds. Another thing to consider are all dosing units available in the EHR should match available units in your pump for continuous infusions. So as you can see, these modifiers here have microgram per minute, microgram per kg per minute, etc. Those are built in because those concentrations are dose unit specific to what they can order in the EHR. Intermittent infusions will be entered as mil per hour. They won't have the specific dosing units associated. Combination medications may need to be entered without drug concentration limits. So for going back to the example of Zosyn, we have to enter that now in mil mode because at least with our EHR, it couldn't take the combination medication to calculate the 3.375 gram. So we had to make it in mil mode in order to make it work with the interoperability. Moving on to a couple more considerations and another example. So in the left-hand side, you can kind of see how in the phenylephrine example, the PICU entries are unlinked to allow for those differences that I was previously discussing with regard to dose rate and infusions, KVOs, custom concentrations, different nomenclature, and multiple medication and concentrations and infusions. So on the left-hand side, phenylephrine is another one that we had separated between pediatric and adults, which we merged into one pump entry and then unlinked the pediatric specific items. So on the right, you can see on the left, on the right picture after integration, the PICU entry of phenylephrine has limited concentrations and has those concentrations specific to that pediatric group that we are using with. And then on the after integration adults, we have multiple concentrations that are used, including a variable to allow for anything that might be a custom made or strays from what our pre-selected concentrations are. Something else that we completed during all of this was workflow testing. So our EHR vendor provided us with a testing toolkit and a list of different workflows and scripts that we would test to make sure they worked appropriately with Interop. So some of these would include new bag administration, rate change or titration, and it would follow specific steps on what we would do or what a nurse would do as they're administering a medication. And this includes steps with regard to their MAR actions and how they would process through that documentation. Some of the other things to call out are emergent back association. So if there's an emergency medication that's started and you don't use Interop right away because you don't have an order, you can go back and associate that specific medication on the pump to the order once it's placed in the patient chart. Another thing are with regard to our heparin and insulin calculators, we tested those special workflows that are unique to our EHR and to Presbyterian with regard to Interop to make sure everything worked appropriately. We also completed negative testing. So this was to ensure that any error messages that a nurse might get were appropriately firing. So this would include a patient ID mismatch, dose rate or volume to be infused that exceeds a maximum, a dose or rate mismatch, an infuser cannot accept program. These are just some of the errors messages that we were able to reproduce along the way to make sure that everything was working according to what was needed and to notify the nurse or the clinician that what they were giving and how to guide them through that. We also completed sample record testing. So each pump entry and EHR infusion or drug entry were assigned a drug alias that was common between the EHR and the pump to allow for that communication. Once the drug alias was assigned, each infusion then required testing and maybe some manipulation to ensure that it communicated appropriately. So each infusion had to be assigned groupers to prompt for and integrate with the pump. This was done on our EHR side. We also had to ensure that the dosing units matched between the EHR and the pump, as I previously described, and then determine what was in scope and out of scope, and make sure that those in scope medications had the appropriate prompts that are needed for integration. We also had Epic IT for clinical nursing with regard to turning on integration using the scope document that was created that Renae was alluding to earlier. The sample record testing specific to the drug entry libraries were completed with 3 Willow pharmacists and 1 medication safety team pharmacist. So once sample record testing was completed, we moved on to full record testing, and this involved the frontline staff. So the drug records in our EHR and drug units were then tested to accommodate for multiple care areas, and to make sure that those different care areas and different medications were working appropriately with the frontline staff and what their normal process is. So we had 1,705 orders placed that were tested by frontline nurses over 3 days. It took 8 pharmacists to enter those orders. We had 10 different workstations set up for the nurses, and there were 20 different test patients. And that, like I said before, included multiple care areas, as well as different facilities, so inpatient and outpatient. So there were 20 nurses from the frontline staff that were pulled from staffing, trained to efficiently test these different orders with the new pump processes and programming. And once they went through all of that, we tracked any issues that were occurring. So our clinical informatics, application build analysts, medication safety team members, our EHR and infusion pump vendors and representatives were all on site during this to assist with that issue tracking. This is just a quick summary of kind of the changes that might occur to look for. I'm not going to go over this. It's a summary of what was previously discussed. And I'm going to hand it back to Renae for objective 3.
Thank you. Here are some of our lessons learned. We could not underscore enough the importance of communicating with your clinicians. One of the things that inevitably came up as a question when there are any changes with workflows or documentation or in your organization, some clinicians and providers may ask why are we doing this, or why do we have to change some of the things that we've been doing? So as a clinical leadership team and a build team, we tried to anticipate what some of those questions were so that we had those answers, and we provided those not only in our electronic resource guides, but we had meetings where a lot of those stakeholders were invited so that we could talk through some of the whys of why we were trying to improve it, why we made certain build decisions, and we involved them in that process early on. We revisited and retrained foundational steps for infusion pump integration and documentation. Again, we had very robust CBTs. We had CBTs that were presented from, again, an inpatient perspective, the department's perspective, so different people could see the exact same workflow and how it would appear, along with the other navigators tools that they routinely use. We definitely increased our focus on and more clearly defined our critical medication titration and specialty infusion workflows. Some examples of those are medications such as oxytocin, our insulin infusions, and other critical medication titrations. One of the things that we also worked to do is identify and resolve language barriers. What we found is that a lot of different clinicians may have been using the word, but meaning 2 very different things, and that a lot of clinicians working in the exact same area called, for example, their unit something totally different. And so it was very important for us to take that opportunity to make sure we all had a reorientation to whatever languages and words that we were hearing for primary versus secondary infusions, continuous versus intermittent versus IV piggybacks. And again, if different people had different names for a department, we needed to clearly understand how that department was named and defined in our EHR, in addition to how people were used to referring to it on their unit. We want to make sure that we that we assessed and that we tested and that we resolved as many connectivity issues or dead spots as existed. And what we were pleasantly surprised by is that a lot of our clinicians already knew where those areas were in their respective units. Again, coordinate environment copy downs and data migration events. We did talk about that, but there is or could be a negative to your training environments and to your testing environments if you're not mindful of some of those environment copy downs. Timing and timelines is important. Make sure that you give your analyst and your training team and your clinicians enough time and enough resources to be compliant and to be successful. We encourage you to set them up for success.
All right, moving on to objective number 4 with regard to our next steps. So set and work towards achieving more goals. We want to achieve compliance and safety goals with integration. So we would like to start doing this by optimizing some of those specialty workflows. Oxytocin and insulin are a couple examples that we have been trying to improve after we went live. So for example, we had infusion for insulin for DKA, and it was a set dose with a range set and administration instructions. We're changing that to be a range order to decrease the alerts that the nurse would get when they're administering and trying to titrate that infusion. Since the set dose that was previously there would have the nurse override when they were trying to titrate to a different dose based on those administration instructions. And they get that on the Epic side and then on the pump side. So that will hopefully decrease all of those. We want to try and standardize workflows and infusions medications. So this is kind of where I referred earlier to ASHP. We're trying to use standardized for safety, their initiative recommendations to kind of streamline that and improve our pharmacy formulary as well as our standard of workflows that are implemented across the enterprise. Also, along the way, we are updating and improving training materials with any new items that come across, and or if there's something that a workflow that might be improved upon with regard to implementation on the units and by the clinicians. As I was saying earlier with the ASHP standardized for safety recommendations, the 4 box items are kind of ones that we're hoping to benefit from with regard to this new implementation. So we wanted to improve the technology integration to increase that consistency and reduce the variation to decrease potential dosing errors and improve efficiency. So with all of that, we would improve patient safety to create a seamless transition amongst different phases of care or units. We want to monitor and improve interoperability compliance. So we're using the pump database, DERS reports, and auto programming compliance to kind of track where we are as far as our compliance with interoperability. And then on the EHR side, we also are still monitoring the BCMA data. And there's also new reports with regard to interoperability compliance, which can be filtered down to facility, units, and different medications to kind of see where we might be having issues so that we can move to improve them. Here's a list of the references we used. And we just want to thank you for your time. And if you have any questions, please let us know.
Thank you, Shannon and Renee. We have one question in the chat. Is it possible to get a copy of the presentation material? And we'll be sending out a follow-up email in a few days after this webinar. Any other questions for Shannon and Renee? So we have a question. Did you come from a Baxter pump previously or a different vendor?
We were using Baxter pumps previously.
Another question, do you require use of interop with all MAR actions, including rate changes, titrations, etc.?
Yes. We did review what our existing MAR actions were. Some additional MAR actions needed to be created for interoperability. And then we have the ability to set with this additional functionality, which one of those new MAR actions actually sent data over to the pump to reprogram the pump, and which MAR actions did not send any information over to the pump, but it would complete the documentation and allow for more discrete data capture of what was actually going on. So we did make some adjustments in how our MAR actions behaved relative to infusion pump integration. And we only did the ones that are associated with infusions. So anything that was previously associated with PO meds or injections or any other type of form that do not have to go over to the pump were not affected by this project. Does that answer your question?
I'll monitor the answer and then we'll move on to the next question. So how long did it take you to optimize your library and how many pharmacists and IT hours were needed? Good question.
Well, as far as like pharmacy IT, we had 3 Willow analysts and myself that were working on testing, and I was trying to optimize the library as we were testing. There's still some things that are being optimized within the library as far as making it cleaner between using interop and manual, with some of the items that are linked maybe between our out of scope care areas and our in scope care areas. I'm unlinking those and kind of maneuvering those so that those pump prompts, the barcode pump prompt doesn't go to example for anesthesia, they were out of scope. So I'm making sure that those anesthesia items are unlinked so that they don't have the interop processes implemented. So I'm still kind of in the process of optimizing as we go and look at different things. As far as time, during the sample record testing, the 4 of us were meeting probably 4 days a week for multiple hours per day. It probably took about half a day, I would say 0.5 if we're talking like FTE for each of them. And then I would also be 0.5 to 0.75, I would say. I don't know as far as IT hours, if you wanted more specifics for like, for example, with Renae's group or other nursing ClinDoc IT, she might have a better answer on that specifically.
I don't have a better answer other than a lot of hours at some points in the project and not as many hours at other points in the project from an IT perspective. So it really just depends on what phase of your project you're in, how many hours you spend. And then initially, as you're becoming more familiar with all of the settings that you need to make, it is a little bit more time intensive, for example, for some of your analysts, but not all of your analysts. So our project, there was a lot of engagement from key analysts. And then as we became more familiar with and had a greater understanding of what bill was required and how the different settings affected different parts of the clinician workflow, then we were able to pull in our training team and pull in those other application team analysts at a point when we had already understood and worked through a lot of the caveats and nuances that may exist from some of the settings, so that when we met with them to present the different options, we could present them with a way to make a more informed decision about those options. Again, I don't have a specific number relative to the hours for each of the application or interface or different build analysts.
Thanks, Shannon and Renae. And Renae, we had feedback on your previous answer and it did answer the question. We have a question here. Did this require a complete rebuild of the drug library, or were you able to use parts of your old Baxter pump drug library?
It did not require a complete rebuild. I was able to use the old Baxter pump drug library. And some of those items, like I said, I had to change from a milligram per mil to a total amount, total volume. And some of them, because our EHR had more available dosing units than what I had previously had in the pump, some of those were built in. So it wasn't a complete rebuild. It's just trying to make sure that those EHR records, there were many more EHR records than there were pump entries. But just with using those modifiers, you can kind of streamline the process to make sure those dosing units and everything are aligning appropriately. And variable concentrations were used as kind of a catch-all. So if you have something that's not maybe a standard concentration in your EHR, which will allow for multiple doses, different volumes, that variable concentration assists with capturing all of those for integration.
So this is a good one. Do you use amount over time functionality in the drug library for IV piggybacks? If so, do you end up having to did you end up having to change a lot of the limits due to rounding differences from EGBIT versus the pump?
Yeah, so the amount over time functionality was under discussion, and this is one of the items we took back to our nursing SMEs with regard to if we should implement. We were going to start with maybe antibiotics, for example. So after discussion with our nursing group, they decided they did not want to move towards amount over time functionality. And so we are using all continuous build in the pump programming currently. And then as far as limits and rounding differences, there are some rounding differences because sometimes that EHR will pull in the BSA or the weight, even if it's not necessarily a weight-based entry on the MAR part, it will still sometimes pull that in. So I do have a little bit softer limits to account for that, but I also have some overfill limits built in too, depending on if the bag is compounded versus premix. If we compound it, I'll allow for 10% from the total volume and include the drug volume if we're compounding. And that's kind of where I built in my upper hard rate limits to include all of that volume, so that if, an example, an outpatient clinic is trying to run something over an hour and they want to get the full volume in, they can go a little faster, as long as it's within the safety recommendations.
Okay, we have how long did you, I think they're asking how long did the project take to complete, which I know, Shannon, you addressed in that one slide, and but maybe you just want to speak to it again.
Yeah, I can speak to that again. So we took about 3 to 4 months to completely do all of the sample record testing for all of the different drug builds and their different units. We did all of that sample record testing within the first few months. And then we moved on to our full record testing and things coming after that. So we did our full record testing about 2 months before we went live. And then I pushed the first library out probably like a week before we went live with the full interoperability starting in March. During that timeline, after we did the full record testing, between that and January and then March, we kind of were triaging all of those issues that were reported during full record testing, cleaning up some of the items that were needed with regard to in scope, out of scope, and planning before we went live with our first site at the beginning of March. And then throughout March, as we were rolling out, if there are any issues that were brought up during our rollout, we would address those in real time and try and get those fixes and or updates to training materials in real time to make sure our next site rollout went smoother.
Renae, anything to add to that?
No.
Okay. I don't see any other questions. I'll give it just a minute here to see if anybody wants to add a last minute one. And we will follow up this webinar with a follow-up email. And we thank everyone for joining today. And thank you to Renae and Shannon. We do have a comment that is saying thank you and that it was very helpful.
Thank you.
Thank you.
Thanks, everyone. Have a great day.